Okay, good afternoon, everyone. I'm Dr. Zhang from Kasai General Hospital. I think because the time is up, so we need to start the session in the afternoon. So I would like to introduce the panelists. We have many commentators, including Dr. Liang Huilong, and Dr. Ding Zhizhong, and Dr. Wu Chenxue, Dr. Ji Naiyu, Dr. Wang Chenjun, and Dr. Amin Rafas. Nice to meet you. And Dr. Seven Branch, yeah. And Dr. Takuya Waguchi, and Dr. Zheng Yizhuo, and Dr. Sorry, Dr. Xue Chaowen, yeah. So this session we have several difficult cases, including the event total occlusion, and Dr. Lee also will perform the BTK calcified lesions in this session. We can start and move to the room one. We will start as the event occlusion, okay? Hello, H 让我加修，听得到吗？ We cannot hear you.
有听到吗？
Yes, yes.
Okay, yeah. Okay, maybe someone can present this case briefly, please.
It's a 77-year-old female with a history of hypertension and hyperlipidemia. She has known chronic DVT in the left iliofemoral segment, specifically a chronic total occlusion of the left external iliac vein. A previous attempt to cross this lesion in April 2022 was unsuccessful, as in this video. In today's procedure, operator may recanalize left iliac vein CTO and further consider placing a venous stent to restore venous patency and significantly improve the patient's venous outflow.
Okay, I think everyone has well known the history, right? So let's go the first imagery, first one. We did common femoral puncture with the echo guide. But at first, you can see the flow. You see the flow. You see the flow. They come from up to down. So at first, we are bizarre. We are doubt if we puncture to the artery. But this is not artery. This is vein. We see next. You see that? You see that? So although the flow go down from the up, but you can see a lot of choroidal vein. I think a bird, and kind of you can see a lot of valve. So this is in presentation the venous hypertension. So that's why it called symptom. And now we confirm by echo and confirm by angio. We can see that the third. You can see that very tiny, so it's a true CTO from the plasma of iliac vein. So we try to use the wire, and I choose the only V18. I think the V18 is very useful. Even if it is, at first it's very soft, but you can cut. It can be very strong. So I try to attempt by the soft end, and surely it's very difficult to pass. So I cut the V18, and then we can see the wire can easily pass. So I have the wire pass to the. For the 11, I introduced the CXI caster. Everything is done supported by the 4 French sheets at first. If the procedure fail, we did not do a lot of harm for the patient. And you see the wire goes to the right heart to the SVC. So I confirm that's the true lumen. Okay. You can see the dye contrast test. You also see that you can identify the IVC clearly. So then we dilated the occlusive vein with the 2-point and a 4-point balloon, and then we check the IVUS. And now you can see the IVUS.
Before checking the IVUS, I want to stop over there because we have several expertise over there. So I want to ask about the panelists about this is a common situation. The iliac vein is the occlusion, and we usually puncture from the femur or the distal femoral vein. So how about everybody about the usual practice in your daily practice? You always use the V18 the same or use the 35 platform to doing this kind of procedure? Any experts want to express?
So no, thank you for the good sharing the cases. So I'm from Japan. My name is Takuya Haruki. I'm from Japan. So I completely agree with using the V18 guide wire, but actually in Japan culturists often use the 014-inch guide wire, but for the venous occlusion, I think the 018 or 035-inch guide wire is much better than 014-inch guide wire because that 014-inch guide wire often go out of vessel. That's why the larger size, larger inch guide wire is better to cross in the venous occlusion. That's why I completely agree with using a V18 guide wire.
Yeah,
this is my personal opinion. But now you use IVUS, but the IVUS often underestimated the size of the venous occlusion. So I want to know how to estimate and decide the size for the stand from the IVUS information. So this is the next step. Thank you. This is my comment.
Yeah. So maybe we can see IVUS right now. Can anybody see the IVUS?
Yes.
Okay, so this is the 18 optical IVUS, and just put back from the IVC. This is IVC, and we can see IVC is very large. And then come back to the, I think this is compression, the compression by the iliac artery. This is very stenosis here, and then down to here. And then the vein is very size very small here, and then we can see the above the vein. This is the iliac artery here, and then come down, and then we can see the some hypercoagulation around the vessel wall. So this is a very I think this is a conic change here. And then this is already down to the common femur, the femur vein here. The size around here is around the 7 millimeter. Yeah. So maybe because the vein is very degenerated here. All the vein size is very small. So I think we can consider as the contralateral size of the iliac vein. Yeah, we check the right side for you.
Before going to the right side IVUS and angiography, is anybody here, everybody will doing the right side sizing, or just use this kind of IVUS to choose the stent size?
Can I ask, do you have any CT venogram preoperatively? Normally you can size it according to the CT venogram, and then you can see the May-Turner point over there.
Pardon, can you speak again?
Is there any CT image of this patient?
Oh, CT imaging. No, we don't have CT imaging. I can show you the the proximal SFV. You can see. Okay. Also, I think this case is very difficult because how to sizing the stent. When we occlude the proximal part, and we can check the proximal SFV. The left side size is not large enough, I think. Yeah, that's one. So it's proximal SFV is not CFV common femoral vein is not large enough compared to the right side. So it's very difficult to choose the stem. And maybe even the puncture part, you see the puncture, you see the external iliac part. There's no thrombus or plaque there. Maybe chronic become shrinkage or become smaller due to the volume did not pass from the common femur. So according to the IVUS, you can only place the largest maybe 8 millimeter stent. I'm very curious if any 8 millimeter stent is enough. But if the stent choose larger, maybe cause the age spasm. So that may be another problem. I don't know the moderator or panelists have any suggestion here.
I think this kind of situation is the distal size is very small and the other size is very big. So from this kind of situation, I want to ask the panelists here, is everybody will choose the smaller stent or the same size stent as the contralateral size?
Yeah, Haris here again from Malaysia. I think based on my experience in terms of the sizing of the vein, not necessarily we have to utilize the IVUS because we know that the DVT will cause the vein to undergo fibrosis and become very small. And it depends on whether it's affecting the common femoral vein as well or not. So that's why I wanted to see the sizing of on the CT scan is possible. If not, then the 7 mm on the IVUS could be probably one is maybe under volume because the vein is actually a capacitance vessel rather than like the artery where it's quite standard and is also compensated by the other side. So most of my cases for the venous stenting, normally in terms of iliac sizing, I will go for maybe around 10 to 12 mm for the common femoral vein to the common external iliac vein. And then for the common iliac vein into the IVC across the Meitner point, I will put in either 14 to 16 size.
Okay, sure, thank you.
Yes, so after revascularization, after getting flow of this vein must be expanded. So that's why for the CFV, so normally I choose 14 millimeter stent, and but if we worry about perforation, maybe I may choose 12, but not 8.
Yeah, sure.
Maybe 8 millimeter size stent will be a position in the future.
Yeah, sure. Thank you. But everyone, you can look carefully. You see, if you look at Angel here, before you found that her SFV was absent. What you see is maybe the choroidal or common femur or profound vein. So it's not true that maybe she have no SFV, and this one may be choroidal. So what we need to do is to decrease the pressure. So if we can decrease the venous hypertension, maybe symptom maybe improve. So I also agree with the 12 or 14 millimeter stent, because when you put the 14 or 12, at first it just maybe can open to the 8 or maybe 10. It cannot reach the 12. So, but later, after a few months or maybe years, you follow the stent, there will be intima grows, and the stem maybe will accommodation with the proximal side, so they will be equal. So maybe I will put 12. Okay. Or another one, one needs to choose another angioplasty with large balloon, or maybe 10 or 12.
Dr. Chen.
I'm Dr. Liang. I agree with Dr. Wu's opinion. I would choose smaller size. And what size? That depends on how many stents that we want to deploy. If we want to deploy 2 stents, then 10 millimeter in the common iliac and 8 millimeter in the external iliac. But if 1 stent, then 8 millimeter for the whole iliac veins. That's my opinion.
Okay, thank you.
Yeah, I think this is a very good opinion because we now have the inflow is just like this. Maybe it's corrector, maybe it's from profunda. So the inflow is not good enough. So I also prefer to choose the smaller stent, just like by the IVUS, because you want to need to decrease in the venous pressure. However, thank you for Dr. Wu, because the room 2 is already, we will exchange it to the room 2, and you can put a stent, just go on. Yeah.
Okay, okay.
老婆，我 move 到 room 2。
先用10的保伦层。
Hello, Professor Lee. Yeah, I'm Dr. Zhang Jiaxiu.
Hi.
Yeah. Would you like to introduce your team?
Okay. I'd like to introduce. Hi, everyone. I'm Dr. Lee. So it's my great pleasure here to have this demonstration. I'd like to introduce my team. So the patient assigned me is the Dr. Zhang and the Dr. Chen. So today we are going to have 1 patient with the CLTI patient. So as you can appreciate that the image is like very calcified dialysis. So allow me to have my colleagues to introduce this patient. 你要介绍一下吗？
The patient is a
okay,
76-year-old female with a history of diabetes, hypertension, CAD staples PCI, atrial fibrillation, and ESRD. She also suffered from bilateral lower limb PLOD. Angiography reveals severe diffuse calcified disease in the anterior tibial, posterior tibial, and peroneal arteries, approximately 70 to 80% stenosis. These lesions were balloon uncrossable. Today, operator may consider rotational atherectomy by RotaPro for the below-the-knee vessels to modify the heavy calcium burden, facilitate device crossing, and ultimately restore crucial distal perfusion.
So, as you can see from the presentation, so this is a patient that with the undilatable from the BTK intervention. But let's check the very initial angiogram today. 来，我们看一下今天一开始的诊断哦。So, as you can appreciate that the patient have very tortuous vessel here. Of course, the main target today is the BTK intervention. We have the lesion for the ATA and also from the TB trunk. But if you appreciate that the angio from here not only tortuous, but also calcified and stenotic. We have checked the IVUS for these patients. So let's switch to the IVUS image.
Okay, can everyone see the image here?
Only see the angiography.
Oh,
Yeah, now here we are. We can see the IVUS.
Okay, the iris is pulled back from the TB trunk. You can see this size here is around 5.56 millimeter. And we have two stenosis lesion. This is the first one. Okay, and then we can go up. Okay, this is the first, the second tight lesion here. Yeah. The minimum lumen diameter is around 2.3 millimeter here.
转弯上来，所以是转是那下面那一个。
Okay.
来哪？来哪？这个样子。
So now we have the severe calcified lesion over the popliteal to the TB trunk, right? How about the panelist opinion for perform this case? Like you were doing the contralateral puncture or doing the antegrade puncture? How many size of sheets you will perform? Dr. Wang?
所以你可以看前面下不去，所以我们就可以。
In this case, I think if you use the
我要18万开始。
contralateral retrograde puncture, I think the probability would significantly reduce when you torque the popliteal tibial segment. And also, it may not be long enough for the rotablator. So I think in this case, if you want to use the rotablator, you have to use the ipsilateral antegrade.
好了，好来，还没到16。
That's the same.
Check. Yeah, for these cases, of course, BTK, especially heavily calcified in end-stage renal disease. I always use the antegrade approach with the 6 Frenchies, longer 6 Frenchies with the tip as close as possible to the target lesion. And yeah.
Yes, for the approaching strategy, for the BTK lesion, antegrade ipsilateral approach is better. Okay. But if there's SFA lesions, the contralateral may be considered. But for this patient, the contralateral lesion, the popliteal SFA lesion is distal, so ipsilateral is better.
If you see this popliteal artery, so you can imagine how elongated the iliac arteries are, calcified, elongated. And this makes it unnecessarily difficult to go up and over. So antegrade definitely here is the best approach.
Because maybe the patient could not stretch his her leg. You can see the popliteal artery is really calcified and tortuous, and so I would like to choose antegrade approach.
松掉。
Would choose if you're doing the antegrade approach.
It depends on the bird size. Maybe 7 or 6. Maybe 7.
然后打底是18。
How about Dr. Ji?
In my hospital, for the first time in approach, we use a crossover approach. For this case, severe torture and classification, if patient has the SFA lesion or iliac lesion, maybe we use the step procedure. Then next time we use antegrade approach for the better support.
So Professor Lee, can you tell me what's your plan? You're doing the antegrade approach, right? And I think you use the 7 French cheese. So what's your thinking about this choice?
Yeah, so as you can see, this is OP80, and the vessel here is very tortuous. we want to, our main target today is the below the knee lesion. Of course, my usual strategy for the ROTA for the intervention is contralateral. But for this patient, because it tortures and calcify, we change our strategy position to the ipsilateral intervention. But as you can see, can you see from the angio from very beginning? 我们看这个. We check the distal femoral lesion here. 再前一组. So if we keep our sheath to the popliteal, because we want to treat the bony with the intervention, we need to overcome this situation. And the popliteal area, if possible, I don't want to put stent here. Today, our main strategy will be the rotablation for this patient. But I like to rotablation for the distal femoral popliteal lesion. So I have just done the rotablation, the 2.5 per. So let's check the angio. 一开始的诊断那个。这个，刚刚那个。So play. So here, you can appreciate that it's a very critical stenosis here. So we have done the rotablation. 下一个。再下一个。OK， 好。So the lesion is distal. 下一个。就这个。We try to pass the rota burr here without ablation, but you can appreciate that it's critical stenosis and tortuous. We cannot pass, so definitely we need a rotablation. I start from the 20,000, and then we can pass this lesion. And then we down slow the rota burr speed. And we have done to 14,000 and 12,000. And this is the angio after the rotablation. I think the result is quite good. So the step is not just now. So do you have any comments from the panelists?
So may I ask?
在5分钟。
So as a doctor, what guide wire do you use, and what size of rotaprobe do you use?
Okay, the initial wire, of course, the Guardians. I have changed to the Rota extra support.
Extra support. Okay.
And currently, we have 2.5 per largest in our country. So 0.5.
Is there any difference between the rotatherapy or rota support? Why you choose the rota support? Can you introduce to us?
Yes. I think that the idea is also from the idea that currently we use in interventional cardiology. So we have the wire bias idea. And if you check from the most lesion, the plaque is over the laser curvature. If you use the rotatherapy, sometimes the rail bias will be the great curvature. And then you have the less ablation from the rotablation. So my opinion, I always use the extra support wire to use the rotablation. This is my practice. And of course, we can check the iris from the image that if their white bias is just over the calcification, and then we have much more confidence to use the Y we choose.
Okay, thank you, Professor Lee, because now we need to move to the lecture. So please keep going on, and we will later to see this case again.
Okay, so this is the angel. So go for it. Thank you.
Thank you. So before the mini lecture, I think徐理事长。理事长要跟我们分享一下。The chief, she will like to share us.
Just bring some wine and you can drink here. And for others, I know still members there, and we also prepare outside, and we still buy the cups. So please wait. Okay.
Okay, so now we can have wine and enjoy the lecture and we. Okay, cheers. Thank you, everybody. So now we move on to the mini lecture, and the next mini lecture is the Professor Ida, right? Yeah.
Okay, good afternoon, ladies and gentlemen. It's my great honor to present my strategy to treat a severe BTK lesion. This is my disclosure. So as you know, there are many evidence focusing on the CLTI treatment, but I think that we should know that this evidence established by the Basel II and the BEST CLTI. So as you know, the BEST CLTI demonstrated the bypass first strategies are better than the endovascular therapy. In contrast, the BEST II demonstrated that endovascular first strategy is better than the bypass surgery. So there are so many different points regarding the treatment strategy, also the patient background, as well as the operator. So we should know the big difference among the country, because in Japan, if you take a look at the patient background, the patient with CLTI have a very poor comorbidity. The diabetes mellitus at 71%, around 70%. Also, the dialysis are around half. It means a very challenging situation for treating the endovascular, also surgery. So we have reported the evidence comparing the bypass surgery versus endovascular therapy. Study name is the SPINIT study. So this is a registry comparing the bypass surgery versus endovascular therapy. As you can see here, the 3 years amputation-free survival was comparable between the surgery and the endovascular therapy. And also we conduct the interaction effect on the baseline characteristics and the patient outcome. As you can see here, the subsequent interaction analysis suggested that there would be the subgroup more suitable for surgical bypass. Maybe the wound condition is more severe. We should consider for bypass surgery. And the patient background is very poor. We should consider for endovascular first. But so there are many evidence focusing on the vascular therapy. This kind of patient is very common in Asia population. This is 80 years old man. BMI was 18.5, and diabetes, hemodialysis, coronary artery disease, and ejection fraction was 50%, low ejection fraction. The right side shows the initial angio before revascularization. He has only the isolated BTK region, and also he has a very poor condition of the inframural disease. So in my clinical practice, so BTK CTO is very, very common, very common. So when and how to reconcile? So our study reported the frequency of BTK CTO ranging from the 40% to 70% in CLTI patient. So because the indication for BTK region is only the patient with CLTI, not for claudication. So in my practice, SFA revascularization in patients with claudication, the CLTI, frequency of the CTO and the SFA around 30 to 50%. That's a big difference from the SFA and BTK. The right side shows the antegrade wire failure. So when using the traditional antegrade approach for BTK intervention, 10 to 20% endovascular intervention failed to the inability to cross the CTO, re-enter the vessel room after subintimal crossing. So who should we consider for retrograde approach? Because in BTK practice, retrograde approach is very, very common for establishing successful recanalization. Left side, published by Dr. Tan, my friend. So this model is the prediction of the success guide crossing for the below the knee chronic total occlusion using the Japanese scoring system. As you can see here, the 5 factors associated with the success wire crossing, including the entry site morphology and entry site classification, and the vessel diameter, the region length, and the condition of the below the ankle. The right side anatomical predictor of the major adverse limb event after infrapopliteal angioplasty of patient CLTI, published by me, so almost 10 years ago, suggested that region classification, the length, diameter, and the length of conditions are strong predictor for success guide crossing as well as achieving the clinical outcome. So based on this study, when you study the endovascular strategy, you should pay attention for the anatomical condition and also imagine the successful recanalization. This is like a representative case. Please carefully confirm the initial angio based on Dr. Tan's presentation, morphology of the proximal stump, and the classification severity of the entry point, and the vessel diameter, the region length, and also we should check the below the ankle condition. So previously, so retrograde approach is very, very common. So how to establish a retrograde approach? There are 3 strategies based on the clinical experience. One is a transtibia approach. This is the most common for treating the long BTK CTO recanalization. Another one is a transpedal approach, like using the transpedal artery. The latest one, the transcollateral approach, like coronary CTO revascularization. I think the most common established bidirectional approach is a retrograde puncture from the dorsal penis artery, the posterior tibial artery. So in my practice, we commonly use the puncture kit, for micropuncture kit, followed by the O18 wire or O14 wire, Gladius wire, accompanied with a microcaster, which is a very stiff microcaster for establish the retrograde approach. Sometimes the looped wire technique is very important, especially the patient with a very tortuous artery. This is a representative case with peroneal artery connecting the dorsal penis artery condition. So as you can see here, the looped wire technique is very useful to connecting the bidirectional wiring. So sometimes this kind of case patient is very common, especially the patient with dialysis. As you can see here, the very longitudinal calcification was found from the initial angio. This kind of patient is very challenging to cross interluminally using the O14 guide wire, even though we have a very skillful wire crossing technique using the O14 wire. I intentionally use the O35 wire system, like a bidirectional approach using the Telumos wire from antegrade and retrograde. This procedure technique is really important to recanalize not only for BTK, but also the SFA and the proprietary recanalization. So let's move on to the treatment strategy. So strategy is determined by the wound severity. So there are so many types of the patient background. If the patient has only the less pain, so we only treat the technical mild region, not touch the long total occlusion. But if patient has the Rutherford 5 or Rutherford 6 and the Rutherford 5 with a very severe infection, we aggressively treat the all vessel. So all clinicians should specifically imagine how amount of the blood supply would be the continuously need for each wound. So each wound are very different from the neediness of the blood flow. That's why I think the personalized treatment strategy is very important to determine the CLTMI treatment strategy. If the patient have the less pain, we only touch just the proximal site region, as demonstrated in the previous case. So in this case, 3-vessel occlusion, but a severe significant stenosis was located at the proximal tibial femoral flank. That's why I just touched on the proximal side. That's, I think, the very reasonable treatment strategy. So previously, the principle of wound zone strategy is very common in the CLTI practice. Understanding the feeding artery to wound bed, identify the potential anatomical variation, pinpoint the specific territory requiring the direct perfusion is really important, including the collateral circulation. So if you treat endovascularly, you should check the wound-related artery. This is a case with a Rutherford 5 with a very severe infection. This patient, this condition, the wheelchair condition, and also she has no usable vein. Vein diameter is 2.5, which is no candidate for surgical bypass therapy. We finally decide to perform the endovascular therapy. And target artery is anterior tibial artery to dorsal pelvis artery because the wound was located at dorsal pelvis side. After angioplasty using the 2 mm balloon caster for dorsal pelvis artery, the 3 mm for below the knee artery, we established a very good flow. The anterior tibial artery is the dorsal pelvis artery. The strategy should be completely distinct the Rutherford 5 from 6, but I think this patient consequence is very nice thanks to the recanalization of the AT at the dorsal pelvis artery. But unfortunately, partially insufficient granulation was found after ATA revascularization. That's why we decided to additionally perform the angioplasty for wound-related artery like this. After successful wire crossing for the wound-related artery, final completion angio is very nice. And patient was, wound was improved by NPWT and the skin transplantation. So finally, I briefly touched the Warrior study, which focused on the wound zone principle, impact on the wound healing. So we have many strategies for BTK revascularization, the angiosome, the wound zone. So we determined the IFU, inline flow to the wound, including the direct revascularization based on the angiosome, and the indirect revascularization with a good collateral defines the IFW. So as you can see here, the IFW has a greater wound healing rate, better than the non-IFW group. And also the study reveals that in IFW revascularization had a higher wound healing rate than the not achieving the IFW, and regardless of revascularization strategy, the surgery and the endovascular therapy. Based on this study, I think that wound-related artery recanalization is very important to get a good outcome. Okay, thank you very much.
Thank you, Professor Ida. Because of the time, so we can have two open questions. Any questions?
No, konnichiwa. Thank you so much for a good presentation. Your presentation is always theoretical and practical. So I follow your strategies. But in the near future, you know, the Esprit product dissolvable stent will be launched in Japan. So that stent will change our strategy or not?
The answer is yes, because Esprit long-term result is very nice. But I think that if patient with a very severe condition of the below the knee artery, it's not candidate for the Esprit BTK, because the longest one, the 38 millimeter, it's very hard to 2 or 3 or 5 stent for the 4 BTK lesion. Maybe we will shift to the revascular strategy for BTK in patient with severe claudication, maybe. So concomitant revascularization, so SFA with BTK was recommended by ESC guideline class 2B recommendation. Maybe if patient has a poor runoff in patient with claudication, we will use this kind of stent for BTK. That's my opinion. Thank you.
Thank you.
So I want to follow in the question, because now we have the problem of the below the ankle of just like the Wunsan concept. So I want to ask the Professor Ida, if you're doing the balloon dilatation to doing the below the ankle for the Wunsan, how many times you need to follow in the wound to healing? I mean, maybe you will recoil or just once is enough? Or
until the wound healing. But I want to revascularization for below the ankle is very, very controversial. Very, very controversial. When I was young, I aggressively dilated all below the ankle, cosmetic revascularization. But after cosmetic revascularization, all branching from the dorsal pterygium and the plantar artery disappear, like a coronary revascularization, losing the diagonal artery. That's why I think that I'm very conservative for revascularization of the BT below the ankle. After BTK revascularization, I check the patient condition, thanks to the below the knee revascularization. It's a time wound healing process is not so bad, and wound healing process is very bad. So I additionally perform the below the ankle angioplasty, partially. My opinion. Thank you.
Thank you. Thank you for it again for the wonderful speech. So now, because the room 1 is already finished, so we move to room 1. Okay, Professor Wu, now we are here. I think you have already finished your procedure.
Actually, I want to ask Ida for one question. But maybe later, okay. You can see that the final. I put 10 millimeter stent. Yeah, according to IBUS. At first, I dilate vessel with the 10 millimeter balloon. Yeah, as we see that first. Okay. Yeah. After dilatation, you can see the vessel become larger. And I check the IBUS. You can see the IBUS. Yeah. Okay. Actually, after dilatation, the vessel become larger. It's not 4 or 5. Yeah, maybe 8 millimeter. So I decided to put 10 millimeter stent. And unfortunately, we only 10 by 10 and 10 by 8 available right now in here. So I deploy first stent. You see the. I identify the IVC with the bone marker and IVUS guide. Yeah, the first stent deployed. Okay, then after deploy, there's some haze appearance leaving here in the common femur. So I deploy another one. Yeah. But as we know, the proximal CFE is very small, so I did not dilate to the 10 millimeter. And actually, I use 8-point millimeter balloon to do the postal dilatation, and just use 3 bar to open the proximal part. And then this is final. And we can check the IVUS again. And you see that, you can see that from the first. Yeah. You can see the stent. It's just not all. It's not cover all the iliac. Yeah. So not to the IVC. So it may not cause the contralateral side thrombosis, and the stent can cover the thrombus very well. And to the distal part, you see that it's attached very well. The lesion was all covered by, you see, there's no gap right here. So I think the procedure I would do just here, okay, and stop the procedure here. Any comment?
Any comment from the panelists? I have several questions about the standing.
Yeah.
Because now we want to put the two stand. Do you have any idea or any controversy about the two stand to overlap zone? It should be anywhere, or the curvature it should be avoided, or any others? About these two stand overlap zone. We choose a longer one or a shorter one? Yeah.
Yeah. Actually, I want to choose the second stand is maybe 10 by 60, but right now it's not available here, so it's much long. It's a little bit longer. But I think it's a daily we will come on facing this problem in the cath lab. Sometimes the device is not available in all sizes. So, but I think 2-layer is not the problem. Yeah. The most problem you have to the two stent, there's no gap in between the two stents. I think the post-dilatation maybe sometimes it's needed if the two stent is different, the size is different. You have to avoid the gap. And after post-dilatation, you check the IVUS, and the IVUS will tell you everything.
Do you think we place the first one is the proximal or this part or the distal part? Will it show any difference or not?
Yeah, I will. You talk the point. Yeah, actually we have to put near the femur first, right? Because this will be identical because we have the smaller one and they put the larger one in the stent, right? But in this case, I think the stent cannot reach its size. So even you put from the distal or the proximal part, I think it's not be a problem. Yeah, but if in the Meissner syndrome, the case of Meissner syndrome, if you have two stents, the singing process may be changed. But in this situation, this patient is chronic total occlusion. I think from the proximal part or the distal part is not a problem. Yeah.
Okay, the final question is an open question I want to ask you and the panelists here. How to define the successful procedure on the table?
My first, right? You can see the first imagery. The patient, there's a lot of iliac vein total occlusion patient, but they did not everybody needs endovascular treatment. But in this case, after puncture the CFV, you can see the flow go from the central to the distal. It's like arterialization. So this representation the venous hypertension. So I think to treat the patient may be beneficial in this situation. And if you did not do the venography, you can also see by the echo. If you see the artery and the pressure are the same signal, maybe they are both red or both red blue. The signal was the same. They mean the venous direction is invert. So this may imply the venous subtension. So I mean, treating these cases may be beneficial. Yeah. And after this, you can see the very nice flow and no corrector, right? So the flow, I think it's successful, right?
Yeah, I think this is a very difficult question. Do you have is any panelists have a different idea or all agree with Professor Wu? Yeah.
The other thing that Haris here again. The other thing that you should look for is the clearance of contrast. So I mean, sometimes you will see a very nice flow, but the contrast stay there, you know. So it could be that there is still residual.
We do the bilateral injection. Yeah, you see. You can see the clearance of the. Yeah, this is final. So it's right. It's nice. Okay.
Yeah, that's good. The other thing is the surveillance, because for me, I think the size of the stent is still a bit too small.
They're small, right?
Yeah, compared to my usual practice. Normally we open up the iliac vein. The size is normally more than 10, probably 12, 14. And size of the common femoral is about 10 mm most of the time. So I think, you should follow up this patient closely. And then what is your strategy for antiplatelet or anticoagulation? Do you give them double antiplatelet or do you give anticoagulation?
I will give the patient anticoagulation for a long time, but I also give the 3 months antiplatelet. Yeah.
Okay, thank you, Professor Wu. Congratulations to have a wonderful procedure. Thank you.
Thank you too.
Now we can move back to room 2. Hello, Professor Lee. Hello.
Hi, So we have now stop. We have now. Let's check the angel. We have done the SFA completely very smooth. 我们先看 distal femoral. Okay. 再往回。Okay. 再往回。哦，这么多，再往回。Okay, so this is the angel that we have done the root ablation, and also after the tri-wedge balloon, it's a scoring balloon here. I think the result here is quite good compared to the very initial imaging. But for the distal lesion, 下一组, I want to pass this tortuous area. So I advance my destination here, try to advance as possible. This is a dilator, 下一组. Okay, so I pass the lesion here, and this is the angel, 下一组. Okay, so you can appreciate that our primary target will be the TB trunk. But here it's very calcified. So we just try to negotiate our wire to pass this lesion because it's very calcified at the stenotic. 下一组，下一组，你就一直走到外那里。So we try several times. Although this flow can pass into the distal area, but the wire is not easy. We change from the Guardius 014 to the Harbor 014. you can appreciate that it's kind of eccentric lesion 一直往下到 distal. Then finally, I can luckily pass this is the Hubble wire to the distal area. You can see there's a very angled lesion just over the TV trunk. I try to advance my wire as far as possible. Here, I can pass the wire to the peroneal wire. But now I have encountered a major problem that only I can pass the wire, but then nothing can pass this area. I have, as you can see, I have added a guiding catheter, try to increase my back support. And then here, this is the smallest balloon from the coronary. It's 1/5. Still cannot pass. And then I try to add another support. This is the extension catheter from the telescope. And still, I cannot pass the lesion with any device, but only the wire. So, do you have any suggestion?
Okay, is everybody have any suggestion for we cannot pass any device over the lesion? What's the next?
So for me, so I control my the guide wire to the PTA, and then do the retrograde approach, add retrograde approach to externalize guide wire. That is better to deliver the balloon and any devices. That is my opinion.
About
the flossing of the guide wire will help a lot to advance any sufficient device to do more predilatation or whatever.
Needle. Yeah, piercing
technique. Yeah. So the Dr. Yang asks you to why not to perform the pierce technique, means we're doing the nickel cracking.
No problem, but not only pass the wire, the lady is crying, and if we pass the needle, I think he's crying and crying. No problem, we can do that.
Or do you want to go in control the wire to the PDA or doing the externalization and doing the backbone technique? Do you think this is maybe useful if you concern the patient is crying?
Yeah, yes. I think another issue is that I think to control the wire to the peroneal maybe it's not very easy because it's eccentric critically stenotic lesion here. I just make a very small curve for the CTO lesion. Maybe directly puncture the distal into the proximal is another issue. I will try that.
Haris here, my opinion. Since the patient is already crying, I mean, you've already done quite a lot by opening up the SFA popliteal tight occlusion. So now I think the flow to the below the knee is much better. So maybe can stage this procedure and then target it later on. What do you think?
Oh, very good. I like that. So, and also this is a demonstration. I would like to delay too much time, so I'll try a little more. If not possible, of course, this patient has we have opened the distal critical stenotic lesion with the Rota Pro 2.5. I think the result is quite good, so I'll try a little more. If not possible, I will stop here. Another strategy is that I try to pass another wire to this critical lesion antegradally and try to open this area with the wire. this is another issue that we don't need to puncture the distal, do the externalization.
Okay, I think Professor Lee, you can proceed your procedure because now we still have time and the room one is already finished. So now we always focus on you.
No.
So I will following the mini lecture and after the lecture we'll go back to your room. Thank you.
然后给我 Astato 20。
这个吗 ？Okay, okay. This is a very busy session for me. Yeah. So I'm the second speaker because now today we have two demonstrations. One is about the lead event total occlusion, and the other one is about the below the knee intervention. So now we will talk about the lead event CTO, mean the chronic total occlusion, the intervention about the Taiwan experience. So I'm the Dr. Zhang Jiaxiu from the Kasei General Hospital. So now today we talk about the vein, chronic, and the occlusion. So we need to define how the anatomy is quite different from the artery. So from the vein, we have a thick external layer, means we had a thick adventitia layer. So when we're doing the vein procedure, we certainly worry about the dissection. We just only worry about the perforation. So we can use the great supported system to doing the passing through the total occlusion. And the chronic means mostly about the venous total occlusion is from the thrombus. So we still need to define the thrombus is quite different by time. So initially we have a quite soft and the shaky-like thrombus. And from the chronic, it will become more stiff, and sometimes it will become just like the scar. So thrombus is evolving, but the evolving is by definition is by the 2 weeks, 4 weeks, or 3 to 6 months. However, we don't define this by the pathology because the patient always have the mixed thrombus. Some is acute, some is chronic, and some is post-thrombotic change. If the patient have a post-thrombotic change, mostly we have the venous hypertension. So from the venous hypertension, we can define an image. How about the thrombus inside? After the post-thrombotic, mostly is fibrous tissue, mostly is fibrosis-like tissue. So maybe it's a scar or honeycomb. So if the patient has a honeycomb-like the lesion, so we can just try to pass through the small channel of the honeycomb or doing the stiff wire to destroy the honeycomb structure. So the chronic is not defined by the symptom, it should be defined by the image. So from the image, just like from the CT or from the duplex of the vein, so we can see maybe your vein is retracted, atretic, or have several irregular wall thickening. We can define it's very chronic. Or from the CT, sometimes we cannot find where is the vein, so because the vein is already a stricture. So from the venography, we can see the vein is always stricture, getting smaller, have an irregular wall, and sometimes you have some recurrentization flow. And we also have dominant collaterals. So we have dominant collaterals, but still the venous hypertension is still over there. So finally, we should discuss how to solve the occlusion. Just that's why I said how to define the successful procedure during on the table. So we try to open the lumen, and the open lumen, and we also need to keep the patency. So from the consensus of operators, we're doing the venous stenting above the common femoral vein, right? So the common femoral vein is above the deep femoral vein. So the location should be located focus on the iliac, below to the femoral and up to the cava. And we also use the IVUS guide to doing the best practice. So we also need to follow the patency rate because if the inflow is not good, we need to more frequently to follow by the Doppler. So the post-thrombotic change is quite a poor patency of the prediction predictors. So it's not closing the ligament. So many doctors worry about we push the stent, we put the stent over the ligament. So if we over the ligament, we worry about the patient will move, will jump, will run in. How about the stent patency rate? So we can find if your inflow is just below the ligament, we should cover all of the lesion. If we cover all the lesion, the patency rate will getting better. So the other question is, can we do AVC by IVUS? We're doing the venous procedure, the IVUS is already is always needed. So of course, if you use the IVUS to check the landing mark, it's not necessary because by the bony landmark, we can see about a comminuted vein, about the IVC, about the inguinal ligament, or the conference level, we can buy the laser trochanter or the ischial crossing. It's always over there. So if you want to just do in the landmark, no, we just need the venography. And the other one is the CT is really helpful. If our patient doing the CTV before the procedure, still need the IVUS. So we can see from the CT, if the cross section is getting smaller and the IVUS is also getting more smaller, yes, some discrepancy. So if we're doing the IVUS, we can see the stenosis rate is quite larger than the CT. So we have a different kind of a definition about the stenosis from the CTV or from the IVUS. And the other one, if every patient doing the CTV, mostly they are MPO, so the vessel size is relatively smaller. So from this CT, we cannot choose whether it's really healthy zone or not. So, but the CT is not really helpful. So IVUS tell us the real-time confirm the healthy zone exactly. So we can do in the procedure, we can decide whether we need to put the stent over there. So the image show, the IVUS always tell us help us to doing the maximize of the visualization. So the IVUS also give us 4 purposes. One is what is inside, and the other one is we can visualize what we do, and we can check the stent upsize, and we can check whether it's true stenosis or not. So just like this, we can see the thrombus just thrombus like by the CT in the superficial vena cava. But from the IVUS, we can see they have some capsule over there, and it's intended to the out of the vessel wall. So I think this is from the tumor. This is a malignancy to invaded to the vessel. So this kind of the patient, we're doing the biopsy, the biotope biopsy, and it's really the tumor of the SCC. So we don't put the stent, we let the patient to doing the radiotherapy. And the other one, we can do in the visualization anatomy in the different states. When you put the stent, we can use the IVUS at the contralateral side, and then we'll put the stent. We can see the stent is over there. So it's more easily to have the exact localization to whether put into the IVC a little bit. So we always use the IVUS as the localization. And the other one is how we choose the vessel size, the stent size. If we choose the stent size, it's quite different by the post-thrombotic change or the compression site. Because from the compression side, if you choose the too short stent, it's more easily to migration. But from the post-thrombotic change, you should choose the equal size of the distal vessel, because now the inflow problem will make your stent more patency. And finally, we always choose the obesity guys always have the legs edema. If we doing the venography, you can see sometimes have the great reflux flow. But if you doing this IVUS probe into the vessel, you can see if he have the inspiration and the expiration, the vessel size will change a lot. So this kind of a dynamic change we should not treat. We always treat the static stenosis. So that's why if the IVUS can do in the real time to see the vessel size, we can confirm the stenosis in the different disease. So the sizing rule of the post-thrombotic change, which the concept is the post-thrombotic change always near the 0. The lumen near the 0, so we just need to get in more lumen size. So it's the 0 from 0, lumen concept is from the 0 to plus. So it's not a conventional sizing of the post-thrombotic change because the inflow is a big problem. If we're doing the conventional size of the venous stem, the inflow is quite small. Finally what? Finally the inflow will decide the final size of the intralumen. So we convince the inflow is the critical point of the distal sizing. So IVUS in the post-thrombotic change, not used for sizing. It should use for confirm the healthy zone. So we should put the stent into the healthy zone. By the venography, maybe we see it's quite great, but sometimes it always have some thrombus over there. So you can see from this side, initially, the distal part is already occluded, so the left distal iliac vein is quite large, so we should have the predilatation of it. After predilatation, you can see the vessel size is getting smaller, so the venous size is always changing. So after decompression, we can have the more actual vessel size to check which size is more better. And the other one is the venous stent shortcoming. Because now we don't have a true idea about the new venous stent, how to protrusion into the IVUS. Because everyone, we have the one stent strategy. So if we're doing the one stent strategy, we don't want to protrude it very much. The less than half of the contralateral side is better. Because in the future, if you have the stent thrombosis, it's a great problem to doing the another contralateral side standing. So we want to ask about this. However, because now the new stent have a quite big side hole, so less and less the contralateral thrombosis is occurred. But we need to pay attention to the protrusion, because if you have the occlusion in the future, the contralateral intervention is a big problem. And the other one, we should avoid to doing the standing at the angulation site. Because just like the picture, if you're doing the angulation side standing, sometimes the turbulent flow will over there, because then the compliance is quite good. So here's less and less elastic. So we can see the small flow, just like the Poisson effect, we will have a turbulent flow to have the inflow of this stent. And the other one is the bamboo stick phenomenon. If we want to put quite size discrepancy standing of the more than 2, we should put the stent from distal to proximal. Because if you put from proximal to distal, it's more easy to make the bamboo stick-like phenomenon. And the other one, if the overlap should not at the curve, because the overlap side is more stiff. If we're doing this at the common peripheral side or at the curvature of the iliac vein, it's more easy to get the stent fracture. So now the barrier of the best practice about the inflow phenomenon. This is from the recent study about the venous inflow. You can see the dark zone means more than 50% of the lumen narrowing. So we classification of iliofemoral tract about the class 1, 2, 3, 4, and 5. If you have lost your femoral vein, it's not easy to maintain your inflow. Especially if your deep femoral vein is also lost, it's not easy to maintain your standing. So you can see from class 1 to class 5, the patency rate is getting less and less. So we also have a similar phenomenon from our experience. So we can see from the 2 means we have a quite good inflow. The distal iliac is patent. So we can see the patency rate is quite high. But from the class 3, we can see we lost of the GSV, so the patent rate is going down about 10%. But we lost the femoral vein, the patent rate is going down from the 20%. But if we lost 3 of this kind of inflow, the patent rate is quite low. So this kind of a phenomenon tells us if your patient is class 5, you should pay attention to it. Maybe you should not do the intervention of a EVT for it, because the patent rate is not easily to maintain. So now we choose several kinds of intervention strategy and attitude about the venous inflow. Above the 1, 2, and 3, we can quite confidence doing the endovascular procedure. And about the class 4, we can maybe combine with the surgeon to doing the endophlebotomy to gain more intraluminal lumen and gain more inflow. How about class 5? Maybe we can try to use the arterial to drive the inflow. So sometimes we use the arterial to drive the inflow to doing the hybrid procedure. Means we have the connection of the artery and the vein to feed in the stent. Maybe you will think the artery pressure is also high. However, because the distal part is already open, so sometimes we also have the puncture problem, have the AV fistula, but the patient did not have less edema, right? So this kind of procedure is the secure procedure, because we use the conservative and the hybrid procedure to feed in the stent. If the patient have the venous ulcer, repeated venous ulcer, we will try to do this. If a patient just have the venous claudication, maybe you should do the conservative treatment about the class 5. So we talk about the anatomy, about the thrombus and the open lumen and the key patency. So vein and the chronic and the occlusion, we should just thinking about the innate, the image, and the inflow. So from the innate, we should use the upstream approach because the distal side approach is more easy to make the recognition. And then we can try to use a supportive wife, and maybe we can try to use a more violent procedure because the aphasia is very sick. And the other is image. The image is quite important because we need to confirm the tension side and choose an appropriate device. If your patient still have the movable thrombus, if your patient still have some acute thrombus hiding in the chronic occlusion, we should try to remove it. And the other one is the occlusion, means the inflow is a big problem because the inflow is quite important for the patients. And we also image the size. We just need to increase a little bit is enough because we can solve the patient's question. So we can show different cases. This is the type 3 inflow procedure. We can, if we're doing the crossover, we easily to misunderstand maybe this is the iliac. However, if we're doing the antegrade approach, you can tell the way is quite different. So we use the puncture from the distal side. I think the popliteal vein is quite good choice. Sometimes the patient maybe did not have a popliteal vein. He also have occluded. We can try to puncture it from the ATV or PTV is also more easy. And this is from the CT. We can see the CT look like they have some compression over there, means with the thrombus right. But after we doing the procedure, we can see the flow is also like seem like the compression side. But if we're doing the IFS, you can see the compression is not very obvious. It's just the organized thrombus. So if we're doing the handmade of the wire-biased thrombectomy, we can maintain the flow. So the patient have the device to remove the organized thrombus. We don't need to put the stent. So the other one is want to choose the closing ligament. So the patient problem is focus on the above and the below the ligament. So we're doing the IVS, we can see above the femur and the deep femur conference, they still have the lesion over there. So if we want to put a stent, we should close the ligament and near the conference. So however, we're doing the antegrade to put the stent, the distal side landing zone is not quite easy. So first time we leave some problem over there, we can see the distal side still have some thrombus over there above below the stent. So follow 1 year, 2 years, the patient patency rate is quite good, but about 3 years, the patency rate is going down. So the thrombus, if doing some fracture, doing some friction or jogging, the inflow is not maintained. So finally, the stent is occluded. So if we're doing the thrombectomy, we have the same problem. Still have some lesion just before the conference and after the stent. So we want to put the stent more precisely. So instead we closing from the popliteal to put the IVUS, and we use a crossover stenting to make the distal landing zone. So just like this, we have the IVUS from the femoral vein to the conference, and we cross over to put the stent. And after stenting, we can solve the problem. So now the patient, the stent can be put very precisely over the conference. The next one is the patient have a quite difficult situation because no inflow of the type 5 occlusion. So the patient have to put the stent in. As you can see, the flow is still very slow. So under this situation, the patient have lost follow-up for 8 years. After 8 years, we don't know what time the stent is really occluded. So he asked us to try to recannulate it. It's very difficult because even we use the re-entry system, we cannot punch through into the stent. So why we fail? We can see the two mechanisms of venous in-stent restenosis. One is from the organizing thrombus. If you find the patient very early, you can try to remove the thrombus and try to reopen and redilate it. But if you find the patient very late, maybe he already has some diffuse intima thickening. So after diffuse intima thickening, it's very difficult to wire in. Even you use the puncture system, even you use the re-entry system, it's very difficult to recannulate it. So from our experience, we conducted the iliac vein occlusion intervention of the Taiwan experience. So more than 6 months or by the image, we can assess the symptom. If the symptom is enough, we can try to use the drug to the conservative treatment and discuss about the further about the intervention. For intervention, we should use the IVUS guide and try to put the stent. But if your patient have a residual thrombus, maybe we need the thrombolysis or thrombectomy to remove the thrombus. And following the inflow type, if the type is 1, 2, and 3, we just do it because the pain rate is quite high. But if the type is type 4, we only perform it in the severe symptom, and we need to follow it more frequently by the echo because it's more easily to get in the stenosis or reocclusion. If the patient is type 5, which is more conservative. If a patient have repeat thrombosis and repeat infection, we will discuss about the hybrid procedure for this kind of patient. So this is my summary. The medicine intervention is emerging because the stenting is always and frequently used, not only in the PTS, sometimes we also use it in the acute stage. And we should choose wisely because the different device should be used at the different thrombus time. So symptoms and the inflow classification is very important. And the best practice of the mental stenting should include in the IVUS. We can do in the stenting very easy without IVUS, but if we have the IVUS image, we can more easy to check the healthy side and make the long-term patterns is more better. So this is my speech. Thank you. Anybody have a question?
John, I see a case about 11 total occlusion with instant total occlusion. I think I saw you bring the patient to cath lab. And I want to ask you, what do you want to do if you can pass the occlusion lesion? What is the next? Okay, thank you.
Actually, I don't want to let the patient into the cath lab. Yeah, because actually why we can re-image it because the patient can lose follow-up for 8 years, means the symptom is not very obvious in these 8 years. So in this kind of a procedure, I pursue the patient to not to do in the re-intervention of this kind of procedure because I don't have quite confidence to pass a lesion. So, however, because the patient strongly asked me to try to pass it, so I would do it. Of course, we fail. So repeat again, I will pursue the patient to not to doing this kind of procedure again. Yeah. Yeah.
I have a question. After the successful standing, how long will you prescribe the medication, anticoagulant? Mersana syndrome or PTS, any difference?
Actually, I have a little bit different medication choice from the Professor Wu. I always give the anticoagulation only. If the patient has the reocclusion, I will try to give another antiplatelet. So if the patient is Mersana syndrome, I only give the anticoagulation for about 6 months. It's enough because the Mersana syndrome is quite good in patency rate. But if the post-thrombotic change, I will give the anticoagulation longer and longer. Yeah, because from the study, whether you're doing the intervention or not, if you after you stop the anticoagulation, it's more easy to get in the rethrombus again. So I will give the patient longer and longer. But it also depends by the bleeding risk. If the patient have a high bleeding risk, I will try at least for 1 year. Yeah. Okay, thank you. So we can move back to room 2.
这条留着，这条拉掉。等我一下哦。14的 IVUS 来，这一条嘛，我看一下我拉错，轻轻拉，哎，这一条没错。OK， 好，可以。石头刚刚。
Hello, Professor Lee. We come back again.
Hi.
Hi.
The lady is still crying, but I'm not going to do the distal puncture. And luckily, let's check the image. 从一开始的那个从一条外开始。So of course, currently we have discussed several techniques for this situation. So finally, I decided to do another wire to puncture this area to do the parawire technique. I use the Sasuke catheter, and the other wire I use the Astato 20. So you can appreciate that the two wires had passed the lesion with the same location. So I now try to advance the balloon with the smallest one, 1/5, to pass this area. And very luckily, I passed the balloon finally in this area with 1/5, and then I dilate the lesion with the 2/15. Now I'm going to check the IVUS to make sure the calcification, and then switch the wire with and to do the rota operation. This is my current strategy.
Okay, because the patient is crying. So how any suggestion from the panelists?
Excuse me, so the second wire is passed through the Sasuke, the side hole, to cross the lesion?
Yes, yes.
Okay.
Do you consider to doing some light sedation of the patient because the patient seems very painful?
Yeah. We have given the morphine. Although I would say the crying is a little exaggerating. If we can keep discussion, keep talking to the lady, she will talkative to us. So not always crying. If we can talk to him, she will talk to us. She will forget to cry. Okay, this is the 018 IVUS. Kind of very tight of this area. If I can pass this area or not. Oh, okay, I can. Can we check the current image? Live. IVUS. Okay. So, yeah. Okay. So, kind of very difficult because very eccentric calcify. Sometimes to use the 018 is still difficult. Do you panelists want to see the IVUS? If you want to see the IVUS, I'll change to the 014. But if not, I'll directly change the wire to the rota wire and to do the rota ablation.
Do anybody insist to see the IVUS? I think we can do in the rota operator directly.
Okay, no problem. So, because the vessel here is not as large as the fin part lesion. Currently in Taiwan, we have two products from the Rota Pro for the peripheral. The first one is the Rota Pro we just used with a 2.5. But for this TP area, I would like to use the 1.5 Rota burr in this area. Currently in Taiwan, we have these two size Rota burr. Okay, right, the Caravelle. Okay. Caravelle. So now I change the wire with the Caravelle and to use the extra support Rota wire. Okay. Oh, 1.5的 burr。
So what's the bird size you choose?
1.5.
So if you cannot pass the IVUS, you just choose the 1.5 bird is your routine, or any consideration to choose the bird size?
Okay, so just as I say, we have two sizes for the rota bird. The first one is 2.5, and the other one is 1.5. So we can appreciate from the imagery, maybe we don't have the IVUS, but maybe I think this area is maybe 3 or 3.5. So according to the strategy in currently, it's the BA ratio is about 0.6. So the best size currently we have is between 1.5 and 2.5. Of course, the 2.5 I think is too large. So I would like to use the 1.5 first. And we are talking in English. The patient is say that she doesn't understand what I'm talking about. Okay, I have passed the parabel. So I would like to use the rota wire here. Okay. 没喝啊，没喝啊。
Okay, thank you, Professor Lee.
5分鐘就好。
I think we can close this session, and the next session they will go back to you to see whether you're doing the outcome of the rotablator. Okay. Yeah,
you.
I think you should have time to proceed to this kind of procedure. Yeah. So thank you everybody now, because the time is limited, so we need to close the session.